Sometimes all it takes to change a perspective is a new point of view. Ergo. Designed to prevent neck and back pains by maintaining a neutral head position. Our new ergonomic custom-made loops allows you to focus on your work for a longer time. A wide variety of frame options available, as well as a multifocal option. Ergo, a new point of view.
Shai, and I'm a representative here at Admatech Solutions. And in the next 15 minutes, I will be speaking of magnification glasses and the accessories that comes with it. So without any further ado, let's dive right in. So let's start with the why. Why do we even need to use loops? Well, the main reason for that is obviously that you can perform your procedures with more accuracy and more quality. When you're working in small areas, tight and complex, it's very hard to precise your work and not make any mistakes if you're not using any magnifications. The loops focuses your vision, enlarge the object that you're performing your procedure on, and takes off the effort and pressure from the eyes and other muscles in your body, such as your back muscles, which actually brings me to the second advantage, which is that you bend less when you're using a loop, because you're sitting or standing further away from the patient. So you're bending your back less compared to without using loops. The bottom line is that you're decreasing the risk of back pains in worse scenarios, irreversible back problems. Now, the third reason is hygiene. The fact that you're sitting or standing further away from the patient take the risk down of mutual contagion. Now, let's talk about some basic terms. Well, the first one is the field of view, and in my eyes, it's the most important parameter that you should focus on when you're choosing magnification. If it's 3 times, 4 times, 5 times, and so on. The field of view is the area or the surface that you're seeing through the magnification alone. The higher the magnification, the less field of view that you're going to see through the loops. The same goes to the second term, which is the depth of field. The depth of field is the range of distance in which the object remains in focus. The higher the magnification, the smaller the depth of field would be. Now, the next 3 terms are parameters that we customize the magnification glasses to the patient, to the doctor. About 95% of loops outside the market today is that kind that's called TTL, through the lens. The other kind is almost extinct from the world, and it's called flip-up, a mechanism that allows the user to change the pubical distance, the PD of the loop, and in within a certain limit, the working distance. When we're talking about TTL loops, it needs to be customized to a specific user. Now, the first customization that we're doing is working distance. The working distance is the distance between the glasses from the object that you're looking at and it is the distance that is the most comfortable for you to work in. It's very important. When you're doing a measurement and you're measuring what is the right distance for you, it's very important that you will sit or stand as comfortable as you can and then take the measurement. Working distance is also a combination of focus and conversion. Focus, obviously, is the clarity of the vision. And conversion is the combination between the left and the right eye to one picture. The second term is pubical distance, or PD. This is the distance between each eye, all right? But when we're talking about magnification glasses, there is high importance to measure each eye separately. I mean the distance between the nose and each pubicle, both sideways and heightways, because we're not symmetrical. And to use magnification glasses that wasn't customized to each eye separately, it's almost as using magnification glasses wasn't customized to you. The third term is optical prescription. If a certain individual has an optical prescription, it's highly recommended to customize it inside the loop and outside the loop according to the prescription. If one has optical prescription, it is very important to put it inside the loop from two reasons. The first one is that the number in your eyes affect the focus. If we will measure a certain working distance and we won't consider the prescription, the end result would be that the working distance will be different than the one that we measured. For example, minus will shorten the focus, and plus will extend it. Secondly, the depth of field, the parameter that gives you freedom of movement, going back and forth and still being focused, will be much smaller if we don't put your lens, your number of your prescription inside the loop. All right. Let's move on to loops and accessories. So when we're talking about loops, I can actually divide it into three kinds of loops. We have the Galilean loops. It's called after Galileo Galilei, and it is two lenses. It has two lenses, just like binoculars. It comes in magnifications of 2.5, 2.7, 2.8, 3.2. The magnifications varies a little bit between the different companies. It's very lightweight. It has a wide field of view and also a large depth of field. And it's very easy to use and get used to. This is the reason why many would recommend you to use them as a first loop. It's also recommended for someone who wants a wide field of view. Now the second loop are the one that I really like, which is the prism and prismatic loop, and it's called capillary loops also, and you might know it by that name. And it was invented by Kepler, a German astronomer and a mathematician. And here the system is filled with mirrors and crystals, crystallized prism. A little bit heavier than the Galilean loop, but still lightweight, and can give you high magnifications such as 4 times, 4.8, 5.5. We're working on higher magnifications than that, like 7.2, but let's wait with that. But the biggest advantage of using a prismatic loop is the high clarity and high definition of vision compared to the other system, compared to the Galilean ones. So this is the reason why I prefer this one, Prism, compared to the Galileans. Now the third kind is the one that's it's called ergo model, sorry, and it's ergonomic loops. It's also prismatic, just like the other ones, but with a twist. It was designed to keep your neck straight, and it obligates the doctor to keep his neck straight in order to see the patient or the object that he wants to see. Here the magnification starts from three times, and it goes up to 10 times. We actually came up with the ergo model more than 4 years ago. This is why we were able to come up with these magnifications. They are amazing, amazing, amazing. It's also extremely light, and besides looking after the doctor's neck, in the long term, in every day, doctor's neck muscles doesn't have to hold your heavy head that can go up to 25 kilos. So you're very exhausted in the end of the day, depends on how long it was. But if you don't have to hold your head, you will be less exhausted in the end of the day. The orchid. Let's talk about light. So the orchid is the wire, the headlight series that we have. We have 4 models. It goes from 80,000 lux, the weaker set of light, sorry, and goes up to 220,000 lux. And depends on what set you're taking. It works in from 4 hours to 6 hours. It has 2 batteries. The more, let's call it sexier headlights are the butterfly evil model, which is the cordless one. Now, this series has 2 models. 35,000 lux, the smaller battery, or 55,000 lux with a heavier battery. Both models working for 2 hours, and you get 3 batteries, or 4 hours if you're using half the second strength of light. So it's very recommended to use not the stronger light. The third one is actually the latest product that we came up with, which is the flamingo, or the camera, which is very cool camera. It's a high definition camera, sits on the loop and shows the point of view of the doctor, of what the doctor has seen through the magnification. It transmits from the central piece here to the computer, and it stores all the videos and photos and whatever on the computer, on the software. You can download the software from our websites, free, and you can also, in the software, you can take still photos, you can edit the videos, cut any parts you don't want from the video, you can crop, you can add stabilizer or without. Very cool camera. Full HD, comes with a built-in light. I don't know if you can see it, but this is the lens, and this is the light. Comes with 2 batteries, also a wireless paddle, so you can start or pause the recording, and so on. And yeah, that's about it. Before I finish my presentation, I would like to say a few words about Admatec. I always like to tell the story about how the company started, and to tell Vladimir Katz, the establisher and the owner and the brain behind every product here in the company. is the inventor here. So anyway, at the beginning of 2000, a friend of his, which is a dentist, came up to him and showed off the headlight that he bought for 2,000 or so euros or dollars. And Vladimir, he's an engineer. He looked at it and he was thinking and saying, I can do better and cheaper. And this is how the company started in 2006. By now, we have over 100 employees, and we are distributing our products. Actually, 95% of the product that we're producing are going outside to, it's actually more than 45 countries by now. So yeah, Admatec is it's really big in the loop industry. And that's it. Yeah. So thank you for listening. Thank you for your time. And I think now it's a good time for you to have to ask questions.
Hello, dear friends and colleagues. I would like to discuss today some of the current information that we have on alternative treatments for obstructive sleep apnea, namely surgical therapy. This set of slides represents my moderator talk to be delivered at the annual American Academy of Otolaryngology meeting in Miami, Florida, as part of my moderator function for presentations on the topics discussed below. I do not have any relation with ineligible companies as far as consulting or being part of medical research team. So the questions we're going to be asking is, in 2024, what is the value of drug-induced sleep endoscopy as part of evaluation process for patients about to undergo sleep surgery, especially in the age of neurostimulation? We're also going to try and tackle an idea of the role of drug-induced sleep endoscopy in the new era of expanded indications by FDA and likely European Respiratory Society for implanting neurostimulation devices. And also would like an audience to think about any pearls from the procedures they perform and some of the learning experience as it relates to patient outcomes. Also, we have to be wary of the fact that as FDA and European Respiratory Society has expanded criteria for Inspire, the most commonly used implant, we have to think about our preliminary observations, since very little data has been published in the last year after this expansion, and also any further complications that may have been observed. So this slide actually shows so-called ADHERE data, which is an acronym for the study, presented to FDA, Food and Drug Administration, for expansion of the use of Inspire implantable device, the most commonly used device in the world now, which shows more of a not really comparable but rather non-inferiority data. It does show that there are very few complications, and the preliminary results are very similar, but if you look at the numbers of patients compared, you have thousands on one side with the old data, old criteria, and only a handful with the new criteria. And again, as you see, the outcomes, again, comparable, but the number of patients are not. So yes, you have significantly improved Epworth Sleepiness Scale, apnea-hypopnea index, those usual metrics that we use, but again, the numbers may not be very comparable. Body mass index, again, comparison data, very similar, based on the increased BMI with expanded criteria. And adverse reactions, obviously very few, but there are very few to begin with. It's quite a safe procedure. And basically, as far as device migration and infection, that were the most common complications, again with pooled data base from 2014 to 2019, again based on the old criteria without expansion criteria, very safe procedure. If you see reportable events, they're very few, just a handful. Count them on your fingers out of thousands and tens of thousands of patients that have been implanted so far. We have to go back to think about Starling resistant model. That's essentially the foundation of current therapy of obstructive sleep apnea. You have to think about the fact that lung volume is critical, and maintenance of lung volume to maintain the airway, at least the lower portion of the upper airway, lower portion of the so-called Starling resistor tube, to keep traction on it. And some of the new data shows that stimulation of the ansa cervicalis has been crucial to maintaining that lower traction of the tube that collapses. And in fact, that preliminary data shows that getting the tube stabilized likely may enhance the stimulation of the tongue itself and control the upper aspect of that Starling resistor model, therefore potentially improving significantly outcomes of Inspire and other implantable devices. Again, this is all laboratory-based, all theoretical. However, something that we should be considering in the future, incorporating perhaps in the implantable devices, not only stimulating the hypoglossal nerve, but ansa cervicalis with its control and tightening of the sternothyroid and sternohyoid muscles, and potentially getting that traction, extra traction to the lower aspect of the collapsible airway. And research has been mostly coming out of Vanderbilt University from David Kent and Dave Zeeler and Alan Schwartz. Those guys are sort of the leaders now in that area, and this shows how ansa cervicalis can be easily localized in the neck. And I have done it in cadavers repeatedly, and you can easily see it during thyroid surgery. It's a very flimsy nerve. We don't pay attention much to it, but something that may play an important role in controlling sleep apnea. And again, localization at Vanderbilt during the experimental studies inpatient has been done using ultrasound, and placement of electrode was percutaneous via ultrasound guidance, stimulating those muscles. Dr. Kent has developed his own methodology doing that, since that has not been done previously, period. And actually, they've been able to show significant change in the surface area of the velopharyngeal airway just by doing that kind of stimulation. So they had a pilot study here. The increase shows significant increase in airflow, so-called Vmax. As far as other things that we should consider at this point is old-fashioned techniques that are still being incorporated. Many countries have not approved neurostimulation yet for a number of reasons, some being financial, some being logistic, and still old school surgery is being implemented. So do we still do genial-glass advancement? In the United States, we do it very rarely and sparingly. In some countries, they still do it quite actively. Unfortunately, the data that we have is only always coupled with multi-level surgery, meaning never tongue advancement in isolation. As we can see, the efficacy data is not that great. It's that 50 to 60% at best, and that's not very long-term results. Long-term, we believe it probably worsens. Success of genial-glass advancement really relies on being able to correctly identify genial tubercle and the belly of genial glass muscle attached to the tubercle, and that attachment has to be isolated and advanced. If full attachment is not captured, usually results are even poorer. There are different techniques for genial glass advancements, procedures using sophisticated technology, like a circular so-called GBAT, with the kit that comes with specifically pre-measured titanium plates to advance the tubercle, as you can see on the very right, versus more traditional way of doing it, getting plain x-rays, understanding the position of the roots of the teeth so those are not harmed, and advancing the tubercle, capturing the tubercle, advancing it with the bone, and then essentially crossing the bone over But of course, there are issues at that point with the cosmetic appearance, with the chin being very prominent, period. And if we already have a patient with a relatively prominent mentum chin, cosmetically it becomes not so complementary. So different adjustments, techniques have been used to cosmetically improve the appearance in those cases. So this is a more of a modified technique where genial tubercle is captured, brought forth, secured with titanium plates. The amount of extension is equivalent to the width of the outer and inner table of the mandible. And then essentially using different burrs and drills, much like in otology, we polish the bone down as it's advanced to cosmetically be at the same level as the original mandible, original chin, to avoid cosmetically poor appearance. The next discussion is about newer techniques in maxillary expansion. As we know, until the age of 14, a lot of children that have maxillary hypoplasia, have obstructive sleep apnea, unable to tolerate CPAP, do well with something called rapid maxillary expansion. However, as the sutures of the fusion plates come together, this conservative expansion is impossible in adults, and therefore Stanford group and a few other groups have developed a surgically assisted distraction osteoneogenesis to get maxillary expander in, and this is some of the techniques used. These are mostly performed by maxillofacial surgeons, but some of the otolaryngologists now have adapted this technique as well. And essentially, this technique allows for expansion, however, also is predicated on the fact that further dental work would be needed. Some of the data looks very encouraging, period. Certainly, very thorough workup with proper maxillofacial assessment, maxillofacial skeletal assessment, be it with a CT scan or proper x-rays, is important to understand the degree of expansion needed and plan surgery accordingly. Complications, relatively few, in spite of us expecting them to be worse. Mostly, again, something that should be able to be corrected with proper dental work, such as dental implants. As you can see, the gaps here, which can be filled with proper implants as the tissue heals and new bone formation takes place. So at this point, I have reviewed some of the old and current techniques in the management of obstructive sleep apnea, both via neurostimulation and some of the new expanded criteria for neurostimulation, namely for Inspire implant. We don't have much data as far as expanded criteria and awaiting publications potentially to be submitted as the numbers start increasing. In regard to genial glass advancement, again, does it have a future? Not so sure, especially with neurostimulation. In regard to expanding neurostimulation to addressing ansa cervicalis and traction of the lower aspect of the upper airway, lower aspect of the startling resistor. I think it has a great future and a potential, and currently studies are being done in that regard. In regard to rapid maxillary expansion, mainly the domain of maxillofacial surgery, certainly in some select patients with maxillary hypoplasia, probably plays an important role. And we will await to see more results since this is a relatively newer technique in adults. We have data for kids, not so much for adults. Thank you.
סרטן, לא מה שחשבתם.
לא מה שחשבתם.
סרטן?
לא מה שחשבתם.
לא מה שחשבתם.
לא מה שחשבתם.
עמרם ביטון, אובחנתי בסרטן קיבה בשנת 2015, ללא טיפול כבר מ-2019, בתקווה להחלמה מלאה.
שמי פרופסור איילה אוברט, אני מנהלת את היחידה לגידולים במערכת העיכול במכון שרת, אונקולוגיה בהדסה עין כרם.
לפני שחליתי הייתי ראש מדור תקשוב במרכז תחמושת. באופן טבעי, בגלל שאתה ראש מדור ואתה עסוק בצבא וכל הזמן יש פעילויות, אז דחיתי את הבדיקות כל הזמן, לא הלכתי לבדיקות. והיה לי כאבים בבטן, הלכתי לבדיקה, לקחו דגימה לבדיקה, אבל הוא אמר לי ישר, אומר לי, יש לך סרטן, אל תמתין. ידעתי שחולי סרטן יש להם את הזכות לבחור את הבית חולים שלהם, ובלי הרבה מחשבה ישר עליתי להדסה, התברר שאני כבר גרורתי, מה שקרה סטייג' 4. ידעתי את הסטטיסטיקות, ידעתי שהסיכונים שלי ממש נמוכים, עד לא קיימים בכלל.
אז עקרונית צריך לדעת שכל שנה מאובחנים כ-800 מטופלים חדשים עם סרטן קיבה, ואחוז לא מבוטל מתוכם מגיעים בשלב 4, כמו שהוא ציין, שלב שיש גרורות. ואצלו זה היה בכבד, בבלוטות בצוואר ומעבר לזה. עקרונית לפי הספר מדובר במחלה שאינה ניתנת לריפוי, ומטרתנו כאונקולוגים היא להאריך את החיים במידת האפשר, תוך שמירה על איכות החיים. לא רוצה לזלזל באלמנט הזה, זה אלמנט חשוב של המקצוע. וזה באמת מה שהוא עבר. מרגע שהוא הגיע, הוא הסבר לו שאני לא יכולה לרפא אותו לצערי.
אתה חוטף את הבום של החיים. אתה לא מבין מאיפה זה בכלל. אנשים לא מבינים איזה טראומה בן אדם מקבל שהוא שומע את הבשורה הזאת. ישר עשיתי קבוצת וואטסאפ למשפחה, כתבתי להם שאובחנתי, וזהו. זה מאותו רגע התחלתי בטיפולים. למזלי הרב, הכימותרפיה עשתה לי פלאים. פרופסור רוברט אמרה לי, מהניסיון שלנו זה חוזר. כשהוא חוזר, זה חוזר במכה יותר חזקה. כלומר, התחלתי עוד פעם כימותרפיה קו שני.
הוא לא נתן לי לנהל את המחלה לבד, הוא היה שותף מאוד מאוד פעיל, זה באמת חשוב. הוא חקר והוא שאל מה יש עוד ולמה אי אפשר, ואם יש בדיקה אחת שלא מצאת שום דבר, למה לא נעשה עוד בדיקה? זאת אומרת, הוא נלחם על החיים שלו יחד איתי.
מזלי, הייתה לי איזו גרורה אחת פה שהיינו עוקבים אחרי, אם הייתה עולה, לא היינו צריכים בדיקות כדי לדעת אם זה עובד או לא עובד. ברגע שהיינו רואים שזה עולה, אז ידענו שזה לא עובד הטיפול, בוא נחליף טיפול. מזלי גם יצא לא מזמן תרופה חדשה לשוק, שעשתה מהפכה בתחום הזה.
ב2 או 3 בדיקות שעשינו התגלה איזשהו רמז ולא יותר מזה, לסיכוי ליעילות של קבוצת תרופות חדשה שהתפתחה, שנקראת אימונותרפיה. התרופות שאנחנו נותנים למטופל דרך הווריד, והן מלמדות את המערכת החיסונית שלנו לתקוף את הגידול. אני לא תוקפת ישירות את הגידול. המערכת החיסונית הטבעית שלנו תוקפת את הגידול, מה שלא קורה באופן טבעי לצערי, והתרופות האלה יודעות לעזור לזה, ובאמת כשקלו כל האפשרויות הטיפוליות, והיינו במצב שלא היה לי כל כך עוד רעיונות, אמרנו נלך על זה. קרטו לו את הבלוטה מהצוואר, והפתולוג עבר על הבלוטה הזאת, שהייתה בלוטה גדולה של איזה 4 סנטימטר, וכל כולה הייתה מלאה בתאי מערכת חיסונית שמילאו את הבלוטה ולא היה בה שמץ של תא גידולי. אני רואה אותו במרפאה וזה נס, כן? נס.
בטח, אין ספק שאני נס, אני יודע את זה. אני גם אומר את זה כל פעם. לפעמים אני יושב וחושב, רגע, אני נס.
גם היום, גם שנת 2024, עדיין אני אגיד שלהבריא מסרטן קיבה גרורתית זה עדיין עניין לא שכיח, אבל יש לנו היום ניסים כאלה, היום בכל מרפאה יושבים איתנו סטודנטים לרפואה ואנחנו עוברים על הרשימה ואני אומרת זה נס וזה נס וזה נס, וככל שהשנים עוברות יש לנו יותר ניסים.
אני בגיל 60 היום, חליתי בגיל 53, הנה תראו כמה שנים, זכיתי לחתן את כל הילדים, זכיתי לראות את הנכדים.
אני חושב שצריך במכון אונקולוגי, ואני חושבת שזה מה שמאפיין אותנו, בבית חולים הדסה, היכולת לחשוב בתוך, כאילו לפי הספר, אבל יחד עם זה ובמקביל לעשות חשיבה מחוץ לקופסה.
ידעתי שהדסה תיתן לי את כל המעטפת, הכל. זה כירורגים, זה אונקולוגים, זה בדיקות, זה הכל, באמת, ואני בכלל לא מצטער, באמת הדסה בעניין הזה הייתה מעל ומעבר. הכל, יש פה את הכל, הכל ואתה מקבל את הכל במקום אחד.
I came to Israel after being diagnosed with a rare condition that affects my immune system, of which I was unable to receive treatment in the UK, either privately or through the NHS. I'd heard firsthand through some of my relatives who live in Israel about the high quality of medical care here in Israel. So I underwent an online consultation at Hadassah Hospital, who filled me with confidence and offered me a treatment plan. So following that, I decided to book a flight and come to Israel. I decided to go to Israel rather than any other country in Europe or America because I've seen firsthand and also heard through stories about how the state of Israel really cares and looks out for the Jewish people. I had every bit of faith that I would be fully taken care of. I have spent a lot of time in Israel, and having dealt a lot with the UK healthcare system, which I know is very rigid, I know the Israeli way of thinking is more creative and more outside the box, which, given the rare condition I had been diagnosed with, I thought would be useful. Yes, the treatment that I require is lifelong immunoglobulin infusions. I'm very, very grateful for the staff at Hadassah who have helped me come to a really great solution. Rather than me having to fly out monthly to Israel, I'm able to collect 4 months of the treatment that I require, which is immunoglobulin, take that home to the UK with me, and self-administer that to myself here. This is after having been taught how to administer the medication whilst in Israel. This is great because it means I only have to go to Israel 3 times a year. I have flexibility. I don't have to worry about where my medication's going to come from, and it's given me real agency. I was assigned a medical advisor whose name is Dimitri, who was absolutely incredible. I could contact him 24/7 and he would help me with every aspect of planning my trip into Israel. So that included writing me a letter so that I could provide passport control, helping me whilst I was in the hospital so that I could know whereabouts in the hospital I needed to be and at what time. Organising the treatments, so for example, planning the dates of when the nurses would be there to teach me how to administer immunoglobulins. All of this stuff was managed by Dimitri, who did a fantastic job and really saved me so much stress because it was very, very demanding and a lot of things had to be managed all at once. Did I have any doubts? No, I didn't. There were some points where things seemed very chaotic and I was worried that I would either have to rebook my flight or things would have to be reorganised, but Dimitri wisely reminded me that how things tend to go in Israel is, although things appear very chaotic, the end result always gets done, and that was definitely what I found to be the case. I would say to anybody to come to Israel. It's completely safe. I felt much safer in Israel than I do in London today. Standard of care is excellent, and I can only speak from the UK's perspective, but much better than what we receive here. The staff are supportive, and yeah, I can't say anything else.
Okay. Okay. Good evening, everybody. My name is Amichai Marovich, and I'm the head of the stereotactic and focused radiotherapy unit at Hadassah University Medical Center. I'm a specialist in oncology, radiation oncology, and internal medicine. And here I will present to you some treatments that can do organ preservation, but not in the classical way that you all hear about, like laryngeal preservation or treatment for nasopharyngeal carcinoma. I'll show you how we organ preserve oral cavity carcinomas and skin cancers that can be treated in other techniques rather than radical surgery with mutilation. And I'll begin my presentation with the large skin cancers that can be treated with radiation. And nowadays, we also give immunotherapy like pembrolizumab and cemiplimab, both PD-L1 inhibitors that can shrink these tumors markedly. And once they are shrink, we can treat them with radiation, and the results can be seen here. When you give radiation, the tumors literally disappears, and the healing process is really good, and people can live for a long time without recurrence disease and without the mutilating surgery that such tumor put them in risk for. And what works for a large tumor can also work for a smaller tumor. And if we look at lip cancers, for instance, this guy with a lip cancer, what we do is treat them with brachytherapy. We bring the source of radiation to the tumor, and we need to insert several catheters, usually no more than 2 or 3 catheters into the tumor, and we use it with the sandwich technique. And here you can see the same guy with this lesion after the treatment, and look how he looks without surgery, without mutilating surgery that will compromise his lip. Another example for oral cavity cancer that can be treated in similar techniques is this one. This is a cancer with this is a buccal mucosa cancer. And look, the cancer is located right near the commissure of the mouth. And the cancer is being treated with brachytherapy. We insert the brachytherapy sleeves in the theater, in the operating room, under a local anesthesia, and they cover the region of the tumor. But we also build, with a maxillofacial rehabilitation unit, we also build a mold that will hold few more catheters that will touch about the tumor from the inside, and also distance the tongue from the catheter so the tongue won't get burned, and the rest of the oral cavity. And here is how the patient is receiving the treatment, like that. This is what's happening a month after the treatment. You see the complete healing, and actually the patient is totally healed. When you look at cancers like that, skin cancer, again with radiation, gone, disappeared. And if patient is unfortunate and have mutilating surgery like this one, you see how the results look like, and the quality of life is much less than treatment with brachytherapy. This is another example of a cancer on the tip of the nose, and that instead of getting a mutilating surgery, we treat him with local radiation, with brachytherapy. The local radiation does not affect the rest of the face, does not affect the rest of the facial organs, and the cure is completed after treatment. Here is another example, and this is the machine that we used. Recently, we received a newer machine for brachytherapy. It looks like E2D2 from Star Wars, but it actually has a safe in this part of the machine that holds a nitinol wire. The nitinol is a flexible metal wire that on the tip of the wire we have something at the size of a tip of a needle, and this is the iridium 192, the radioactive source, very active radioactive source, that goes with an engine out from one of the 18 holes in the machine to the point that we direct it with the computer. So we can control where this nitinol wire goes to. For instance, here it goes in the beginning slowly, and then it becomes faster. Or here it's slow, then fast, then slow. So the radiation amount depends on the time that the source stays at each point through the route of the travel of this nitinol wire. And the time points that it stays called dwell time, dwell points, and we control it with computer where it should stay and for how long. So we can give such treatments with great success. Here is another example of a patient who was a heavy smoker. You can see that he is a heavy smoker from the nicotine stain on his beard that have a 2 centimeter lower lip lesion. We told him to shave his beard before the treatment. This is how the lesion looks like. We distance the lesion with a mold from the mandibula, so it won't get a lot of radiation. We insert 2 sleeves. You can see here is the lesion. We insert 2 sleeves to the lower lip and build a mold on the tip of this lesion. And this is how it looks at the end, and that's how the patient receiving the treatment for about 5 consecutive days. He received treatment BID twice a day in the machine. This is the simulation. This is how the patient receives the treatment, and this is the result. No cancer, and the patient is happy with, he can open his mouth. There is no scar there. There is no mutilation to the muscle, the orbicularis oris, so the patient does not suffer from drooling or from microstomia, narrowing of the mouth orifice and opening his mouth. And actually, I followed him up for more than 10 years now, and he's doing well without a recurrence of his disease. It works also for larger tumors, like you can see here, and without surgery, the radiation results are excellent. You can see here again, more than 10 years later, you can see that he has Angelina Jolie lips without surgery and without mutilating him to take the cancer out by other means. These are very sensitive cancers to radiation, and radiation is the way to treat them. Another example of upper lip cancer that you can see here, and if the surgeon wants to take this cancer away, he has to take at least 1 centimeter away from the cancer, from the induration. So you see the induration here. And if you take 1 centimeter margins from that induration, the patient for sure will have microstomia, a very small mouth orifice that will be non-functional. He will be able to suck from a straw, but not eat an apple or a steak properly because the mouth will not open. So he chose to have the brachytherapy technique, our brachytherapy technique. We build him a mold. He received the treatment with distancing the region from the maxilla. In this case, you can see that the insertion of the needles, 3 needles here needed, the building of the mold. The mold is transparent, apparently. This is the mold in the way that we build it, and this is the way the patient receives the treatment. And he received the treatment like that for 5 consecutive days. And this is how he received the treatment in our brachytherapy suite at Hadassah. This is during the treatment. He comes twice a day, receive the treatment for 5 to 7 days, and this is the results. The end result is no tumor and functioning mouth that he can open with a minimal cosmetic deformation. No surgical procedure can give such results. And this is an example of patient who had surgery for a large lip tumor, and you can see the mutilation that this surgery can cause. So this mouth is non-functional and he has drooling for life, so he will spoil the liquids out of the mouth because he cannot close it efficiently, but he also cannot eat efficiently. You cannot open the orbicularis oris more, and this is mutilating surgery. This is another example of mutilating surgery with attempt to reconstruct the lower lip, but you see how bad it looks, and the patient have tracheostomy. This patient literally wrote me that he had better died than live like that. And since it's not functioning as a lip, and he cannot close the mouth properly, he also had drooling from the side of the reconstructed mouth, and this was a terrible, terrible outcome compared to what we can offer the patient with brachytherapy. This is how we calculate it with a computerized calculation using the CT scan. This is another example of a large lower lip tumor. You can see how it looks, and you can also appreciate that the patient received also with radiation a little bit of Erbitux. So he has these pimples from the Erbitux. This is how we received the treatment, and this is the mold that we built for him during the treatment, immediately after the treatment, and this is how the patient recovers. So minimal defect to the lower lip and excellent cosmetic results. You can see and appreciate it here. It also happened, we published this data a couple of years ago, and I can show you also that we can use the same techniques to tongue cancer. This is a woman, old woman with a mobile tongue carcinoma. She had a partial glossectomy and the margins were positive. So the surgeon offered her a hemiglossectomy. She refuses to go for another surgery, and we came up with a brachytherapy to the tongue to compensate for these positive margins. We inserted three sleeves that the radiation will go through to the tongue, and we distant the tongue from the mandible, and this is the end results. 6 months after, you can see that this is a tongue after a partial glossectomy, but without evidence of disease, and the disease actually never recurred to this woman. So it cured her from her cancer. Another example is this gentleman with anterior tongue carcinoma, and this carcinoma happens from this dentition that was built with a metal, and you can see the metal part here that was abutting the tongue, and after years, it developed a cancer. This is a squamous cell carcinoma, poorly differentiated, highly aggressive, and obviously the surgeon offered the patient a total glossectomy. This patient used to be an ambassador, and what he thought that he was living on, that's what he said at least to me, that he was living on his tongue, on speaking all his life, and he's rather died than not having the ability to talk and to speak. And he was seeking for another solution rather than a total glossectomy. And we offered him indeed the brachytherapy technique for that. And he is receiving this technique here, you can see that, with computerized calculation of the doses. This is how he received the treatment. This is the calculation of the treatment. You see that we are avoiding the mandible. We distance the radiation high doses from the mandible, but we cover all the region of the tongue. This is the mandible, this is the tongue, and this is the coverage that we achieved. And the most important thing here is that once we finish the radiation, this is the day that he finishes the radiation, and this is about 4 weeks later. You can see that he has a mobile tongue that can move, and this is the tongue and how it looks like without evidence of disease. This is before and this is after, and the patient lived a few years later without evidence of disease, only to succumb for a lymphoma that he developed that probably was unrelated to that cancer or to its treatment. Thank you very much for your attention. And if you want to ask me any questions, you can do so, and I'll be happy to assist. Thank you.
Okay, hello everybody. My name is Professor Ronil Yashar. I'm the chairman of the Department of Otolaryngology, Head and Neck Surgery at Hadassah Hebrew University Medical Center in Jerusalem. And my main practice is rhinology and endoscopic skull-based surgery. רגע, לא עובד לי, yes. רגע, בואו נתחיל מחדש, כי משום מה זה לא עבד לי.
אין בעיה, התחלנו.
Okay. Hello everybody, my name is Professor Ronil Yashar. I'm the chairman of the Department of Otolaryngology, Head and Neck Surgery at Hadassah University Medical Center in Jerusalem. My main practice is rhinology and endoscopic sinus surgery. And today I will talk to you about chordomas and chondrosarcomas of the anterior skull base, a shift from transcranial to endoscopic resection. And I also may add the significance and obstacles of complete surgical resection of these tumors. So if we talk about endoscopic skull-based surgery, we know that it's a surgical approach through both nostrils. When the endoscope is the sole visualization tool, bringing all eyes close to the surgical target site, as can be seen from the pictures below. You can compare the round picture using the endoscope to the other picture using the microscope, and you can see how it brings the obstacles closer to the eye. The technique is also called the two nostrils forehand technique, as can see below, doing by two surgeons. So the nose and the sinuses are really the corridor to the anterior skull base. As you can see here, in endoscopic approach through the nose, we can reach all the way from the bottom of the frontal sinus to the lower third of the clivus, a very long part of the anterior skull base. And if we add the transoral route, we can even get lower to C2 or even 3C, which is really in the neck. So why should we use an endoscope instead of a microscope? First of all, there is less morbidity of the surgery with equal or even better results. We have to consider that there is another brain instead of solo neurosurgeon operating the patient. There is also the brain of the rhinologist, and there is better visualization, as demonstrated here. You can see on the left that if you have a narrow corridor, when you use the microscope, your field of view is very narrow. However, if you use the endoscope, you have a larger field of view. And also on the right side, you can see that using the microscope, again, you have this narrow field, while the endoscope can pass through the narrowing space, showing a wider field of view. And if you use an angled endoscope, it can even show you around the corner. And this is a demonstration. On the right in the B, you can see the view of the sella as the neurosurgeon used to see it while working through the Hardy endoscope, the Hardy speculum and the microscope, while the same sella looks much larger when using the endoscope. So what enables endoscopic skull-based surgery? First of all, highly qualified skull-based surgeon, the neurosurgeon, and a highly qualified endoscopic sinus surgeon, the rhinologist. And I compare it to a dance. When you have two dancers, they have to really work very, very close together in order to achieve a good quality dance. The same is done in this endoscopic skull-based surgery team. What else enables endoscopic skull-based surgery? First of all, knowledge of the anatomy, imaging for diagnosis, planning, embolization, navigation, equipment such as high-resolution imaging, navigation systems, debrider, ultrasonic aspiration, aspirators, cleaning systems, and dedicated instruments, and of course, nerve monitors. You should have a support team such as endocrinology, ophthalmology, oncology, plastic surgery, invasive radiology, etc. You should know all the reconstruction options which are very important in skull-base surgery. You should know how to treat the patient post-operatively because they can be really complicated to treat. And you need to be able to use highly experienced training centers and cadaveric courses in order to reach good technique during real life surgery. And this is the team of Hadassah. Some of you may know Professor Sergei Spector and Dr. Emir Margulin. They prepared this presentation with me previously. Unfortunately, they left Hadassah to other hospitals, and today I work with Professor Andrew Kay, who came from Australia, from Melbourne, and Dr. Samuel Moscovici. Both of them are very highly qualified skull-based surgeons, neurosurgeons. So let's talk a little bit about chordoma. It's a rare tumor with an incidence of 1 to 1 million cases per year, and it appears along the axial spine between the clivus and the sacrum. You can see from the image that 50% of the cases appear in the sacrum, and where it's the most common primary malignant tumor, and about 35% appear in the spheno-occipital region, most commonly in the clivus. And this is obvious because the chordoma develops from the residual embryonic notochord, and you can see it, its expected location along this green line in the figure. And most chordomas, fortunately, are extraosseous remnants that they appear, therefore, extradurally. The mean age for diagnosis is around 60 years, but often with skull-based tumors, younger patients are affected. Patients may present with headache, diplopia, or impairment of other cranial nerves. Due to its slow-growing nature, resulting in insidious, not specific symptoms, diagnosis may be delayed, and therefore the mean time from onset of symptoms to diagnosis is more than 2 years, which is a very long time, and therefore many cases present with large tumors. Skull-based chordomas are locally aggressive and destructive lesions with high recurrence rate. Most tumors eventually become fatal neoplasm, unfortunately, and following recurrence, it has a dismal prognosis with 3 and 5 years survival rates of 43% and 7% respectively, and therefore the management, once chordoma recurs, is mostly palliative and not curative. When we shift to chondrosarcoma, it's a rare malignant cartilage-forming tumor. Most commonly, it occurs in isolation, but it can also develop in association with several things, such as non-hereditary skeletal disorders producing endochondromas, such as Ollier disease and Maffucci syndrome, previous irradiation, previous intravenous use of thorium dioxide contrast, which, as far as I know, is not in use anymore, osteosarcoma, malignant melanoma, fibrosarcoma, and leukemia, and benign pathologies such as fibrous dysplasia and Paget's disease. So why do we group chordoma and chondrosarcoma together? First of all, because they are similar radiologically with only small differences. Second, they are similar macroscopically with small differences. Pathologists hardly distinguish them on frozen sections. Therefore, decisions at surgery are often made without a firm diagnosis. We enter the surgery, we know that it can be either chordoma or chondrosarcoma, and we don't know until we get the final pathologic results which one of the two it was. Surgical policy is similar for both tumors. Both are radioresistant, therefore high doses of irradiation are advisable if you give irradiation to the patients. The main difference is in prognosis, as we'll see later on. And here we can see histology of chordoma versus chondrosarcoma. Because they look similarly in regular histopathologic slides, we have to use immunohistochemistry. And you can see here that both of them share the S100 protein. However, chordoma has a specific other immunohistochemistry staining, and mostly known as brachyury, which is typical of chordoma. So we can differentiate these two tumors after we use the immunohistochemistry staining. Treatment principles are, as we said, similar because they are locally aggressive and destructive tumors with high recurrence rate. Both of them may have fatal outcome. Hence, they should be aggressively treated at the onset of the treatment with the most radical approach, meaning radical surgical resection, usually with irradiation. And again, I'll refer to it soon. So if we talk about radical surgery, the question is at what price? So if we use this cadaver and dissect to the area where these tumors appear, we can see that we reach very rich neurovascular areas, and radical surgery may cause lots of morbidity in these patients. So at what price? I'm going to show you some articles about the treatment of these tumors. And the first article is published in 2017, compared the treatment on progression-free survival in patients with skull-based chordomas. It was a retrospective study of 234 cases. And what we can see from these Kaplan-Meier's curves is that gross total resection of the tumor is better than near total resection and better than intralesional resection, both in progression-free survival and in recurrence rates. If we use, again, we use the SEER database. The SEER database collects cancer incidents from population-based cancer registry covering approximately 35% of the US population. It collects data on patient demographics, primary tumor site, tumor morphology, stage diagnosis, and of course of treatment. And they follow up with patients for vital status. So in this study, they used the SEER database on 416 chordoma patients and 269 chordomas patients. And their results showed that postoperative radiation was given to around 40% of patients. However, its addition did not improve survival, which is very interesting. Another study from 2014, looking at outcomes of patients with chordomas, again using the SEER database. This study was conducted on almost 400 patients between a long time period from 1973 to 2009. They had a mean survival rate of 150 months. 10th survival rate was lower in patients receiving radiation. Again, very interesting. But however, this decrease in survival may be due to a selection bias. And it's interesting to watch again the Kaplan-Meier curves showing that surgery alone had the best result in treating chordomas. Another study again from 2014, again using the SEER database. This study used it on 226 patients, again on the same time period. 93 patients had surgery and only few received radiation after diagnosis. And again, in this study, surgery confers survival benefit. This was not statistically significant, but again, surgery and radiation had a lower survival than surgery alone. Another study from 2017 from World Neurosurgery. They looked at a large number of almost 1,600 patients with chordoma, again using the SEER database. And they were trying to look at about prognostic factors and survival outcomes in patients with chordomas in the United States. And what they found was that older age, greater tumor size, and distant metastases were correlated with decreased survival, where surgical resection correlated with increased survival. And again, patients receiving radiation therapy also showed decreased survival. This is again probably because they had a more advanced disease. However, in this meta-analysis from 2018, they looked at 22 studies with a large number of patients, and this was from the years 1993 to 2017, so it's later on, probably with better radiation than in previous studies. They found 5 independent predictors of poor prognosis: older age, preoperative visual deficit, classical chordoma subtype, non-total resection or intralesional tumor resection, and lack of adjuvant radiation therapy. And they concluded that we think that radiation therapy may be routinely considered to improve survival rate and quality of life in patients with skull-based chordoma. And this, I have to say, this is the common practice. So usually, despite the data that I showed you before, we now tend to give postoperative radiation to these patients, to most of these patients. So if we talk about radiation, in this study, they found that the optimal treatment strategy was surgical resection and high-dose radiation, more than 74 gray. And if they compared the different modes of radiation, carbon ion had the best results compared to proton beam and IMRT or stereotactic radiation surgery. So what are the question controversies when you look at all of the above studies? First of all, extent of removal, but at what price? Radiation therapy, yes or no, and what type? How much can we build on the efficacy of radiotherapy? Can precise irradiation replace surgical excision? Specific technical questions regarding strategies, surgical technique, approaches, and stage surgeries. And I want to show you our experience at Hadassah. We looked at our experience in 20 years of operating these 2 tumors. We had exactly 50 patients operated on from 1998 to 2018. 38 of them, 75% were chordoma, and the rest were chondrosarcomas. The mean follow-up was 73 months with a range of 3 to 204 months. Mean tumor volume was 14 cubical centimeters. Mean age was 42 years with a range of 14 to 69, and there were about half males and half female. If we looked about the tumor location, we can see here on the left that the chordomas had a strong midline predisposition. And this is obvious because, as we said before, it originates from remnants of the notochord, which is in the midline. Chondrosarcoma was more lateral than the chordoma. The surgical approach, most cases of chordoma were done using the midline approach, while most cases of chondrosarcomas were done via craniotomies. And now if we look about the evolution of the surgical technique, we can see that before 2010, before we at Hadassah really had a good endoscopic skull-based team, most cases were done using the craniotomy. However, from 2011 and on, most cases, almost 90% of the cases, were done using the transnasal, transoral endoscopic approach. So this is evolution of the surgical technique from the craniotomies open technique to the endoscopic technique. This is our operating room. As you can see here, we use the neuronavigation, we use electrical neuro monitoring, and this is how it's done during the surgery. If we look at our results with the extent of the resection, so gross total resection or subtotal resection were possible in 50% of the cases, meaning that most of our cases were really, really huge cases, large cases. Most of the cases received radiotherapy. About 80% of the cases received some type of radiotherapy, which we believe is good. Only 8 cases did not receive any radiotherapy. Obviously, we had some complications. When using the transnasal transoral approach, we had one surgical mortality, basilar artery injury. I'll show it later on. 4 CSF leaks with 3 meningitis and 1 epistaxis. Cases with craniotomy, 1 stroke, 2 CSF leaks and 1 meningitis. And we had cranial nerve pulses in both approaches. What were the outcomes? We had 37 chordoma cases. As we said, 50% were able to have a subtotal or total resection. We excluded one patient who underwent only biopsy and then underwent treatment in another hospital. So he was excluded from this analysis. And here our outcome. The good result is that, as we said before, most cases received postoperative irradiation, and none of the cases who had subtotal resection did not receive any radiation. It means that all of them with subtotal resection received radiation, and only 2 cases of total resection did not receive radiotherapy. This is the bad, a little bit more the bad part. It's a busy slide, but we can see that we had several deaths in our series. And the main conclusions from this analysis is that partial removal, we have to give radiotherapy as we did before. Biopsy has the worst prognosis. This is obviously obvious from the results that I've shown before. And multiple procedures have a bad prognosis. When we shift to chondrosarcoma outcome, it's a little better. Only 3 out of the 12 cases are dead with a longer follow-up of 10 years average. So the prognosis of chondrosarcoma is better than the prognosis of chordoma. This is seen also in these Kaplan-Meier curves. You can see here that in 5 years, the 5-year survival of chordoma and chondrosarcoma was almost the same, 81 and 81 and 90%. However, the prognosis in 10 years and 50 years of chondrosarcoma remained 90%, while it dropped to 40% for chordoma. So the prognosis of chordoma is worse than those of chondrosarcoma. And this is seen here if we compare the extent of resection for both chordoma and chondrosarcoma. We can see that gross total resection and subtotal resection have much better prognosis than partial resection or biopsy. And if we divide them on the right to chordoma and chondrosarcoma, the trends remain the same. So always gross total resection or subtotal resection are always better, of course. If we add the effect of radiation, we can see that the extent of resection had a greater effect on progression-free survival than the type of radiotherapy. Either stereotactic radiotherapy or proton beam radiotherapy. What's really important is the extent of the resection. So I want to show you some cases. I'll start with the case of chondrosarcoma. This is a 50-year-old woman. She manifested with diplopia and facial numbness, and you can see the tumor on her right side. She underwent craniotomy with gross total resection. The pathology returned chondrosarcoma grade 1. She did not receive any radiotherapy later on. And then she underwent corrective surgery for 6 nerve palsy. And in a 10 years follow-up, there is no evidence of the disease. So this is a good case. And I'll shift to chordomas, which is more interesting in my eyes. And I'll show you some cases. This is a good case. In 2006, I remind you that at that time we did not have a good endoscopic skull-based surgery team. This is a 30-year-old woman. She presented with headaches, ataxia, and diplopia. She underwent surgery, left transpetrosal translabyrinthine approach. At that time, again, we did not have an endoscopic approach. gross total removal, and histology was chordoma. And you can see the post-op images here. She did not have any adjuvant radiotherapy, and 12 years follow-up, no evidence of disease. Normal neurological exam, except for left ear deafness due to the surgery that she underwent. So this is a good, successful case. The second case, I've called it a bad case. In 2011, you can see the initial MRIs here with a big tumor. This is a 35 years old man with he presented with right cranial nerve 6 palsy. And again, you can see the tumor. In April 2011, he underwent craniotomy. At that time, our experience in endoscopic resection was a little bit limited. So we elected to resect this tumor via craniotomy. So he underwent craniotomy, and during the surgery, a very calcified tumor was found. It was a chondroid chordoma, and it permitted only partial removal. Post-operative, he had the 6-nerve palsy. His 6-nerve palsy resolved. He had the right ear deafness, again, because of the lateral surgery. And otherwise, his course was unremarkable. Later on the same years, he got a photon and proton beam therapy and a total maximum dose of 68.4 gray, which is now considered too low. But at that time, this is what was given to him. 4 years later, he returned with a new left cranial nerve 3 palsy. And at that time, we felt that we can do it endoscopically. So we did an endoscopic transnasal removal, resection, postoperative MRI. His, again, 3rd nerve palsy resolved. And his postoperative MRI can be seen here. Later on, he presented with bitemporal hemianopia, and he underwent a second endoscopic removal of a tumor, a residual tumor. Postoperatively, a little bit later on, in January of 2017, his vision improved. However, in November 2017, again, he had tumor progression, and he underwent a 3rd endoscopic removal. A year later, January 2018, at that stage, he was after craniotomy in 2011, after proton beam and photon radiation in 2011, and after 3 endoscopic surgeries. And in August 2018, only 7 months later, terrible progression within 6 months. And you can see the huge tumor here after all these surgeries and after radiation. And this is our worst case, a 59-year-old lady with a huge cleval chordoma. In October of 2015, she went on transpentrosal resection at another hospital, resulting in right hemiparesis and several cranial nerve pulses. And you can see the tumor, the postoperative tumor here. This is a CT angio in preparation for surgery. You can see how the basilar artery is deviated by the tumor to the left. This is during surgery. I'm going to show you a little bit, a short film. You can see how the dura was very involved. There was intradural tumor adherent to all the cranial nerves and the basilar artery. And we had a very difficult time in resecting it. So we decided to use the Covidian ultrasonic aspiration, the CUSA, which can be seen here. We wanted to debulk only the extradural part and the more lateral part. However, this is what happened during the surgery. Suddenly we got this bleeding. It was obvious that it was from the basilar artery. And we were able to stop it by using pressure. And as you can see here, however, This is her post-operative imaging. You can see the hole here in the basilar artery. The arrow shows it, a small hole, and you can see around the brainstem the bleeding, and unfortunately, she later on passed away. Chordomas of the craniocervical junction are the most difficult cases in our view. The principles are transoral transnasal approach, craniocervical fusion because you have to deal with this area. You should consider tracheotomy because of airway issues. You should consider gastrostomy because of nutrition issues. You should consider staging and sequencing of the tumor because they're so large and the resection is so demanding. And in our eyes, the major risk factor is does the tumor cross the dura or not. You can see on the left side the tumor before, and on the right side the tumor after resection. And I'll present also a few cases here. The first case is a 24 years old man with an incidental finding, as you can see here, the normal neurological exam. He underwent surgery, both transnasal and transoral, with cervical fusion. As you can see here, the pre-op and the post-op images, small residual tumor, and we had to decide whether to reoperate him or irradiate, and we decided to give him only radiation. You can see here that he got this time 75.6 gray, and as I said before, the amount of irradiation, the dose of radiation increases with time. And in this patient, 5 years follow-up shows no evidence of disease. So this is a successful case. The second case, the 16-year-old girl, she presented with left hypoglossal nerve palsy. Again, you can see the very large, the huge tumor here. It turned out to be chondroma. This time we decided to stage the procedure. First of all, we did a transnasal endoscopic resection, and then 2 months later, a transoral combined with transnasal endoscopic resection, this time with a craniocervical fusion. Again, we have a small intradural residual tumor here with a dilemma whether to add additional surgery or to rely on radiotherapy. And we decided again in this time to rely on radiotherapy. Again, more than 75 gray of targeted irradiation, and 4 years follow-up. This patient is no evidence of the disease. And the last case is the most challenging case that we had. It's a 16-year-old girl. She presented with snoring to an ENT. He did a fiber optic examination and saw a lump in her nasopharynx. Initially, he thought that it's adenoids, but then he reconsidered. He sent it to imaging, and you can see the huge tumor here in her nasopharynx. So again, we staged her. The first surgery, which took us a long time, and we did tracheotomy, we did the gastrostomy, transoral microscopic and endoscopic and transnasal endoscopic removal of the major part of the tumor, with removal of the cervical occipital junction and anterior part of the upper vertebra. We took a nasoseptal flap. We harvested at the beginning of the procedure, and we used it to fill the empty nasopharynx after the tumor removal. And retrospectively, I think it was a mistake because we, at that time, we did not open the dura. So really, we lost the chance of using the nasoseptal flap for closing the CSF leak later on. And again, this dura was not open, and we left the intradural part of the tumor for a later stage. And obviously, we did the cervical occipital fusion. So this is the reason why we have to do a cervical occipital fusion, because otherwise the head, the calvarium has no where to rely on, and then there's no stability. So you must do a fusion. Post-operative course of this first stage of the surgery, she developed a retropharyngeal abscess requiring prolonged treatment with antibiotics. significant extra and intradural residual tumor, as can be seen from the imaging here. She recovered completely with no neurological deficit or swallowing problems. And then we did the second stage of the surgery. At that time, we did endoscopic removal of the residual tumor, both extradural and intradural retrocleval tumor. And we were able to completely remove the tumor together with the cleval dura, which was embedded by the tumor. Obviously, we used the neuromonitoring. And I'm showing you a small part of the surgery. You can see here the dura removed with the tumor. Using this, you can see there were large tumor behind the dura, retrodural. Here we work on the hypoglossal canal. You can see also the brainstem here very nicely with the basilar vertebral arteries and lower cranial nerves. And there's a large opening that has to be closed. So we really had the difficulty in closing it. She underwent 3 later on surgeries for CSF leak, and then we were able to close the gap efficiently. She then, after she recovered, she went to have post-operative radiation therapy. We used proton beam, and again, increasing the dose almost to 80 gray of irradiation, which is a very large dose. 1.5 year follow-up MRI, you can see here, good result. And the question is, what is the horizon? If I summarize all the cases and the data that I presented, what are the horizons? How can we improve the technology? Maybe by self-targeting devices. And I'll just show you this small movie of Arnold Schwarzenegger. Okay, so maybe this is the way to remove. Oops. Sorry about that. Just a minute, I'll go on again. So sorry about that. Maybe this was the way to remove the tumors. But if we become serious again, probably gene profiling and cellular and molecular biology characterization will enable us to treat better both chordomas and chondrosarcomas in the future. So in conclusions, these are some of our conclusions and probably some of our questions. We can see that aggressive tumors demand aggressive treatment. The best results are with small contained tumors enabling radical removal with clean margins. Survival strongly correlates with extent of resection, and surgery therefore should be radical as possible, but again, at what price in mobility and complications? Maximal first-line treatment should be given as recurrent tumors are related with bad prognosis, and maybe recurrent tumors are interestingly more aggressive and grow in spite of treatment. Who knows? Adjuvant high-dose radiotherapy is recommended, but it is not clear what type and what dose. Surgery and radiation-based therapy have similar limitations, tumor margins, and there is a shift from craniotomies to endoscopic resection, probably not only in our hospital, but everywhere elsewhere. Rescue surgery and rescue radiotherapy fail. Therefore, the best chance is first choice when you see the patient. And there is a question, when can we define the patient as cured? 10, 15, 20 years? We don't know. The future will probably rely on genetic and molecular characteristics, as I showed you before. I thank you for your attention.
Thank you.
Sometimes all it takes to change a perspective is a new point of view. Ergo. Designed to prevent neck and back pains by maintaining a neutral head position. Our new ergonomic custom-made loops allows you to focus on your work for a longer time. A wide variety of frame options available, as well as a multifocal option. Ergo, a new point of view.